Okay, so welcome to Meducate Academy. Today we're going to be looking at the role of the ACE and what it involves. I explained on the previous sort of webinar that Associate Clinical Educators were role players on steroids, maybe I called it that, medical role players on steroids, which means we take it to the next level. So as well as giving feedback on a student's communication skills, and how well they interacted with the patient and built rapport and so on. Your task as an ACE is not only to be able to do that, but actually also be able to have a basic grasp of body systems and the tools of the trade, of the medical trade. Okay, this obviously takes a bit more commitment than just performing, because it implies that you have to go away and do a bit of reading, but you don't have to learn medicine.
And to be honest, there are not that many body systems to learn, so it's not too bewildering from that point of view. And they're done over and over, aren't they? So you know, there's a run of work basically where you take the students through the various body systems, so you get used to them from that point of view, because there's not loads and loads.
I think there's actually 7.
That's all, isn't it? Cardiovascular, respiratory, GI,
cranial nerves, musculoskeletal. Yeah. And just to make it clear that when me and Mark started doing this about 12 years ago, we were given very little training. And we did all of the background reading ourselves and worked together with students learning on the job. I don't want that to happen, because I think the quality then suffers. And the idea is that we have regular assessments to ensure that the ACEs that are working with us are all at the same sort of speed and rate. We're gonna talk about that a little bit later, because I'm sure you'll have questions about how the training is going to take place and what the assessment process is, and obviously things like fees, because that's pretty important to an actor, you know, earning a dime.
And of course, you also find yourself teaching clinical communication, because the role play doesn't go away. Quite often we'll do a role play before the examination, which is a wonderful kind of realistic simulation of a full consultation. So you will find yourself feeding back on comm skills with the students as well, and you will find yourself role-playing on a regular basis.
And there's a lot of jargon as well that you're going to pick up on the way. We're going to try and be jargon-free, but there will be times when we'll use it and explain what we mean by that, because medicine, like any other science, any other field, has its own language and its own jargon. And you need to know the jargon, but these are things you pick up as you go along. You know, I'm still learning new things all the time, and I've been doing this 12 years. But what me and Mark have got, and a few of our ACEs, certainly about 10 of us, have got a really good fundamental grasp of the body systems and how they should be examined. I think it's important to say we're not expected to talk about diagnosis or medical conditions. Our job is not to do that. No. Our job is to give feedback on the technique, isn't it?
Absolutely. We're not talking about pathologies. We're not teaching them why they're doing anything. We're just making sure they do it properly. And this can be as simple as where they place the stethoscope. So
Mark used the word there, pathologies. I'm going to assume you don't know what it means. I apologize if you do, but that's a problem with, you know, a pathology is I have a condition. So like I have a pathology, and that's a hip pathology, and it's osteoarthritis. And on that note, actually, it's quite good if some of our ACEs have got medical conditions, because you won't have to act it. Some of our ACEs have got scars from operations, which are pretty valuable for the student to see. So if you actually have pathologies and you're not afraid of, you know, allowing the student to have a look at them.
I'll tell you a funny story. The guy who set the ACE program up, Professor Jim Parr from Birmingham, I had atrial fibrillation in 2013, which is where my heart wasn't pumping properly. And it makes your pulse thready, feel a bit odd, not regular. And I got cured. And Jim said to me, he said, "Thanks, Mark," he said, "for getting cured." He said, "That was really good teaching." So there you go. How about that? So I don't know if Bob gave you originally an overview of how the ACE role started. It was started by Professor Jim Parr for the Birmingham University Physician Associate course. And really, people like Bob and I have taken it to a different level, because originally it was just going to be a resource where a layperson fed back very clearly and simply about how the examination was carried out. And we've kind of taken it to a level now where we actually are clear to teach, because the idea was the ACE would never teach a student how to carry out the examination in the first place. That'd be done by an academic. But because of our skill set and knowledge base, we're actually allowed to do that now. So we have taken it to a level it was not originally pitched at. And that's up to you. If you want to take it to that teaching level, it's up to you. Or if you just want to be somebody who feeds back how well the examination took place, you know, at that level, that's fine.
So we envisage, you know, in the future, certainly once COVID sorted out, that we're going to get our let's say, get our hands into a lot of other universities. So wherever you are in the country, there's going to be an opportunity for you to be working.
The reason for that is physician associate students don't have leave breaks like medical students do. They don't have time on an intense 2-year course. They're always working, either on placement or in teaching. So there's always work available with physician associates. I'd like to talk about something, Bob, in terms of how successful the ACE role has been. Spearheaded at Birmingham by Professor Jim Powell, became a unique selling point on the Birmingham course, and students started to sign up to the Birmingham Physician Associate course because they heard it was good to work with Associate Clinical Educators. And when feedback is carried out at the end of terms, we always score very highly in terms of our effectiveness and how much they enjoyed working with us. One of the reasons, of course, students like working with us is because we are lay people. We're a bit less scary than academics and clinicians.
Yeah, that's a really key point. The students always feed back to us and say, oh, we're glad we're working with you and not the academic, which is bizarre. But obviously, it takes a bit of time to get to that sort of level of ability. I mean, we're putting a sort of, me and Matt were talking about this a while back, and we're thinking of, once the training's taken place, there's like provisional. You're sort of provisional for 6 months while you get the skills. We'll put you on the job in 6 months, but you'll be shadowed by, you know, an experienced ACE. So you'll always be with someone to give you a help, if you like, because there's going to be things that you come across that you will never have encountered, even on a training course. And people like Mark, me, you know, Alison, Helen, Dave, it was quite a big team. Greg will be able to help you with that. And
I was talking to you earlier about the idea of a buddy system. I mean, I'd be happy to be your buddy, your mentor. I'd be happy to swap my, you know, number, and you could call me about things or talk to me about stuff anytime, and help you and work with you. That'd be fine, that kind of thing.
Oh, yeah. Well, as we said on the webinar originally, we're really transparent about our aims and our ideas here. It's to get a lot of actors in work. I've been an actor, I know what it's like. That's why I created Meducate, because I just wasn't getting enough work. And the other thing is that we're here to help you at every step of the way. So, you know, all of you have got my email address and my contact, and you can always contact us through the website. And Mark, as I say, he offered this morning, he said, look, I'm happy to mentor people if they need it. And that's the aim, is to get everybody up to speed, to work as a genuine team, to have a really good dynamic, ensuring that we all work together as a team. I was talking to Matt, and I think Matt might have something to say about that as the other director of the company. We actually talked about having genuine away days where we have just a good time together. No fancy motivational games or any of that nonsense. Just, I don't know, going where we were going to go. The south of France, wasn't it? At your expense, Matt. Or has Matt, oh, there, he's still there.
Yes, at my expense, Bob, yeah.
Yeah, so Matt's going to pay for it. You heard that. Matt's
recording it as well, Bob, so that's really worrying, isn't it?
So I can hold you to that. No, but seriously, it's about just getting the team together and having a good time once a year, you know, once COVID's out of the way and we're established.
Meducate want you to enjoy being an ACE, and Meducate want the students to enjoy working with you as well.
Yeah.
We, you know, people who are engaging, who enjoy teaching and can make the experience a positive one for the student. Sometimes you've got to be firm with them. Sometimes things will happen where you've got to rein them in. But my motto is firm but fair. But we try and do things with a twinkle, don't we, Bob?
Oh, yeah.
And make sure the students enjoy the sessions.
I think, and that's one of the key things of Meducate. If any of you have taken the time to sort of look at the Instagram account and YouTube and the Associate Clinical Educator.com blog, you'll see that the students love what we do. They really do. And I mean, you know, I know we're singing our own praises here, but actually it's nice to hear the students come back and say, when are you coming back next? It's always nice to hear that, because of course the students are now customers in education. So they're paying $9,500 and a bit more to learn medicine.
Yes, their expectations are high of the kind of service they'll receive, and quite rightly so.
And so and once the ACE program becomes more commonplace around the country, we're going to start seeing definitely more universities saying we need ACEs. We've talked about the role of the ACE and communication skills, okay? Have any of you guys got any questions? Now,
Bob sees me. Bob and I work together a lot. We are the Captain Mannering and Sergeant Wilson of the ACE world.
Laurel and Hardy.
And Bob will agree with me here. I teach because Bob and I work together every week. I teach week in, week out to students. I say to them, don't lose your humanity. Don't be a robot. You are a human being with a set of special skills. And it's amazing because they get focused on the academia of what they're doing. They forget to be empathetic. And this happens all the time, doesn't it?
Yeah.
And, we're not backwards in coming forwards about this. No. And we do difficult scenarios and they completely miss things. All the stuff that happens, I mean, so many times over the years. For example, I've been a guy with migraines and my wife died last week. And I say to the student, my wife died last week. And they say, okay, how long have we had this headache? And you go, ah! And then I really pull them up.
Yeah.
And they get it, but it's just, they think they are a scientist. Yes, goodness knows medicine is a science, but it's a huge bit of it is empathy. And there are always situations in the role plays that we do where empathy has to be brought out, and when it gets missed, it's a huge learning outcome for them. So so we're very big on that.
Well, we did something. We were working in London last week, and with an organisation, Matrix Education, and Mark was doing a scenario with a girl who was blatantly very nervous about doing role play, but it was important to get it right. And we finished the role play. And Mark says, "Right, let's go back in and do it again," because of the mistake she was making. Okay, so we were able to stop them and say, right, let's start the whole, let's pick it up again from that point. Let's do it differently this time. So we got there, we got her colleagues to sort of give us some feedback, to sort of help her along, and we were very supportive, and she did a better job.
Yeah, and that's what we say to them. We say, look, this is a teaching session, and we say to them, if anything goes wrong, it doesn't matter as long as you learn from it, and you don't do it out there, because one of the great things, I mean, you can't consult with a real patient and say, how did I do? Was I good? Is that all right? You can't say that as a doctor or a physician associate. So working with us, things go wrong. We don't get hurt. They don't get hurt. They learn something from it and they don't do it again. And that's great teaching. So it's a very safe and supportive environment. I was horrified, wasn't I? I'm very active on Twitter. He's the king of Instagram, I'm the king of Twitter, and I was horrified by a recent tweet from a medical student somewhere up north, not in the Midlands, who said, I'm fed up of having to act my way through medicine. I did not sign up to become an actor. And I tweeted back and said, you're not acting, you're actually being yourself. I'm the one who's playing a part when I'm role-playing a patient. You're being yourself. Because the assessors, at OSCE and whatnot, have to see what you're like for real. When you really consult, you don't pretend to be something else. You don't pretend to pass your driving test, do you? You don't pretend you're Daniel Craig or the Stig to pass your driving test. You do it for real. And it's the same in medicine. And some people have a problem getting their heads around that. But what we have to say to them is, look, you be you. You do what you would really do. Yeah. And I will respond accordingly. The assessor wants to know two things. They want to see that you're very good at your job, you know your stuff, and that you're safe. Same as passing a driving test. Can you drive? Do you know how to drive? And are you safe to be on the roads? And some students do struggle with this aspect of it and the sort of the simulation part of it, but we work hard with them and they get it in the end. Because although I'm not a real patient, I'm a real person. I can give real responses based upon my emotional response to what you say, and they get it, don't they?
Yeah, they get it.
And it's great teaching.
And it's about bringing, and Mark said it, we constantly emphasize how they should bring their humanity to the role play, to the ACE work when they're physically examining us. Because once you're physically examining someone, you've got permission to physically touch them. Yeah. If you haven't got rapport at that point, they're not going to want to take their shirt off to start with. They don't want to be examined by somebody who doesn't have any humanity. So I always ask the student, particularly the students who struggle, I'll say, why are you in healthcare? Why did you choose medicine? And invariably what they say is because they care about people. Okay, so bring that same care to this scenario, to this session today. keep that in the back of your mind. I'm doing this because I want to help people. So make all of your mistakes in the session. Come on. Most of you guys are actors, right? Why do we rehearse? To get it right on the night. Simple as that. That's why we rehearse. And we don't beat ourselves up because we fail in a rehearsal. You think, thank God I'd made a mistake in the rehearsal because now I'm improving, because we learn by our mistakes, and we tell the students that make as many mistakes as you can with me. Auscultate the wrong place. Yeah. Look in the wrong part of my anatomy. Don't look at my mouth. Come on, get these mistakes and learn from them. And of course, because we're not academics and big and scary, the students have a laugh with us and we say, let's do it again. Let's start from the top. And by the end of the session, they usually go away feeling more confident, because that's the key to it.
Yeah.
They want to walk away feeling confident. And our job is to give them that confidence that they can interact with us on a communication level, but more importantly, be able to physically interact with us hands-on, moving us in a way that doesn't cause us too much pain, unless it's musculoskeletal, which is a different thing we'll talk about. But certainly with things like eye examinations, we were doing ear examinations the other day. So we had to guide the student with the otoscope to make sure they had it in the right position, that they were putting it in carefully, so they didn't cause any discomfort, because some people are scared of physical examinations. So when you come to actually physically examine someone, you want to have total trust in that clinician. And our job is to give that person that, all of these things. Yeah. So they all fit together. The role play, the clinical skills all come together. And you as a person as well. It's about bringing your personality to the table as well.
Was there another
so we always have a scenario, Lorna.
One of the first rules of medical role play is not to talk about things you've had, not to push your own buttons about stuff, really. So, okay. Yeah, so it's always a created scenario. Sometimes they're generic ones for teaching purposes. Sometimes we can actually create something the student wants to learn from it. I mean, quite often I've had a situation where students want to work with an angry patient or a difficult colleague to see what happens and to give them some strategies for dealing with that. So sometimes we can base it on their needs, but quite often, I mean, scenarios last for years, to be honest, Laura. You know, you can just keep rolling them out. As long as the students don't give away the content to their peers, you can keep using them, you know. So that's quite useful, really. But no, and you never use your own name either. This medical role play business is always third person. So I'm no longer Mark Reynolds, I'm John Smith. And then you feed back as John Smith and how John Smith felt. So it's not necessarily based upon your own emotional response, but it's that of how the patient you're playing felt. That's where the performance aspect comes in. And it's maybe sad sometimes to see students genuinely offended or upset by the person in front of them. No, that actor in front of you was playing a part. It wasn't them. Yeah, they were playing a role. And quite often students can't disassociate the actor from the role, and they get genuinely affronted or offended by people. It's very sad when that happens. One of the ways you can kind of get around that is by giving yourself another name, so it's not you. And when you feed back to the student how it went, you would say, John Smith felt that when you said blah, 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 you know. So it's never about you, it's never about your own experiences, it's about the part you're playing.
So it's quite good because
you will get screened.
You will get screened. So when Mark had AF, arterial fibrillation, he would actually tell the students, oh, by the way, I have AF. Or if he wanted the student to try and find it, it was quite useful.
And let me tell you, you know, if you've got a lump or a bump you're not sure about, if you've got 5 minutes, I'll tell you.
It's a great way to get an MOT.
I've saved so many GP appointments.
Yeah. There's no other questions. We've talked about pathologies. We've talked about your experiences and how you should be with the student. We've talked a little bit about the equipment. I've mentioned an otoscope, an ophthalmoscope. You've all seen a stethoscope. Okay, that they call it the guessing tube.
Yes, they do.
Right. In the business. So you'll learn about using the equipment. Okay, and it's basic equipment. You're not expecting to be able to read an ECG. There's only stupid nerds like me do stuff like that. But you will learn where they should put the markers on your body to take an ECG. You will expect it to help the student learn to use the stethoscope correctly, tuning forks for vibration, the otoscope, the ophthalmoscope. Some of you have probably seen a blood pressure cuff. Yeah, so you'll be helping the student learn to take blood pressures.
Can I just, this is a big part of your life, colleagues. The couch.
The couch,
It's
yeah.
where you're going to spend your life, you see, like that. Looking up at the ceiling on this couch. This is going to be where you're going to spend 90% of your time, I was thinking.
Yeah, yeah, on a couch. A typical respiratory exam, okay? So I'm going to play the ACE, the clinical educator. Mark's going to play the student.
Mark is not licensed to practice medicine in any form at all. Just want to point that out.
You just pointed that out. So Mark's going to play a physician associate student in their second year. And notice the whole process. He's going to wash his hands before and after. We even, right from the start, if the student doesn't wash their hands or they don't have the sleeves rolled up above the elbow, bare to the elbows, we mention it.
Now then, obviously at the moment, students are wearing PPE. I would imagine that by the time you start to work for Meducate, hopefully all that will be over. But at the moment, students are working with a mask on. We've got a mask on. They've got nitrile gloves on and an apron. We're not going to worry about that for today. It's happening at the moment. So I hope when you guys are on board, let's hope all that's over. But they would still wear nitrile gloves for 1 or 2 examinations.
Yes, for certain examinations, they would wear gloves.
Yeah.
So
we're gonna bend the rules this morning because we have no. He hasn't bought any PPE. Can't believe it. Honestly, he thought he'd have bought some PPE. Luckily, you've been vaccinated, Robert.
Yeah. So, are we ready?
Let's do it.
Right.
So this is exactly how it will be for you. This is how we'll run through, and we're going to run it through in real time. It takes about 8 to 10 minutes. Obviously, if they're starting off, it's going to take a long time to do this examination. But we're going to assume the student kind of knows what they're doing, and they're going to run through it pretty damn quickly. All right, we're not going to labour this. I'm going to give you an idea of what it'll be like from beginning to end. Good afternoon, sir. My name is Mark Reynolds. I'm a second-year physician associate student. Could I have your name and date of birth, please?
Yeah, it's John Smith, 30th of the 8th, 56.
How do you want me to address you, Mr. Smith?
John will be fine. Thanks.
Okay, great,
Yeah.
John. I've been asked to carry out a respiratory examination upon you.
Yeah.
This will involve me looking into your face, your eyes, checking your hands, listening to your chest and tapping on your chest. Is that okay?
That's fine. Yeah,
okay, thank you. For this examination, I need you to take off your t-shirt, please.
Okay, yeah.
Note the PA is moved away from the patient while they take the top off. This is very important. Never ever have a PA or medical student watch you undress. That's highly inappropriate.
Okay, Mark, I'm ready. Can I just stop you there? Right, just a little thing. Did you wash your hands when you came in?
Oh God, no.
So if you just go and wash your hands,
Yes,
never forget that. Okay. And there was one other thing as well. When you're talking to the patient, okay, did you know how old this chap is? 56.
I took your date of birth, but I didn't work out how old does that make?
So, little tip, okay, little tip, Mark. When you get a date of birth of someone, just say to them, if you don't mind me asking, how old does that make you? Because you're going to have to give feedback to the examiner.
It's hard to do the maths on days of birth, you know.
Exactly. So that makes them 64. So now you know immediately when you're giving your feedback to the examiner that the chap is 64-year-old male, John Smith, blah, blah, blah. Yeah.
Okay. That's great. Okay.
One other thing though, Mark.
Yeah.
You need to look around the bed.
Right.
Okay, so you need to look around the bed.
Look at that now then. So I'm looking around the bed. I can't see any respiratory aids. I can't see any sprays. The patient seems to be comfortable at rest. So you're not tripoding, you're breathing normally. That kind of thing?
Yep, that's fine, Mark. Yeah. So always look around the bed. Walking aids, respiratory aids.
Okay.
Inhalers.
Yeah, good.
Peak flow meters. That type of thing.
I should remember that.
Yeah. No. It's part of it.
Can I take your pulse, please?
Yeah, you can.
Take your pulse here.
So is that how you start a respiratory exam, is it?
I usually start off with a pulse. Yeah.
No. Okay, let's go back a bit.
Okay.
Right. So stay there.
Yeah.
Right. So you can see me.
Yeah.
You've already looked from the end of the bed.
Yeah.
Right. So get the patient on the couch.
Right.
Should the couch be at 45 or should it be flat for
45?
45, absolutely, yeah. Okay, so the patient's here now in position.
All right. I've been doing it with them sat up just to do the pulse like that.
You need to look at them, don't you? What are you looking for? What are you looking for?
Scars, shape, symmetry, any wasting, any spider nevi, any lesions.
Spider nevi, that's a GI exam. But if you saw it, then you would mention
you
it.
would, wouldn't you? I mean, if it was there, you wouldn't.
No. What do you prefer to do first?
I do pulse and respiratory rate first, and look at the hands and lips and mouth.
Okay, fine.
Okay, so I'm going to check your pulse for 15 seconds.
So what is it you're doing there? Tell me what you're doing there.
So I'm taking your pulse. I'm also subtly checking your respiratory rate.
You shouldn't have that watch on there, Mark. How many times have I told you? Have it on your belt.
Yeah, it's all right.
You because obviously in terms of a hygiene.
I know.
Yeah.
It was a present recently. I haven't taken it off.
No. Always have you.
Okay, so I got your pulse at about 65 beats per minute. It was regular. Your respiratory rate seemed to be about 12 to 14.
Okay, so what you did there was you took my pulse for 15 seconds, times by 4, and then you looked at my breathing rate times that.
Yeah.
Okay, great.
Okay, now look at your hands now, please. Okay, looking at your hands. They are warm, well perfused. I'm checking for capillary refill.
Okay, and you hold that for
5 seconds. Fine. Okay, could I look at your face
one
now,
more
please?
thing.
So much looking on the hands.
Come on, think. CO2 retention.
Oh yes, could you put your arms forward like that for me, please, and cock your wrists back. I'll leave you there for a few seconds. I don't see any signs of CO.
And how long will you leave that there for in the real world?
30 seconds.
Yeah, in the exam you won't have that much time.
Look upwards, please. I'm looking for any anemia. It's nice and pink and well perfused. Thank you very much indeed. Looking around your eyes, I can't see any fatty deposits. No.
What are those called? Can you remember?
Is that?
Remember, jargon's really important.
Xanthelasma?
Second year, you're a second year. Come on,
Xanthelasma?
Xanthelasma. Yeah, well, we'll have to work through this. Okay, so we've done the face.
Yeah.
Great. Yeah.
Okay. I now want to check for tracheal deviation. Is it okay if I put my fingers into your throat here? It might be
of course. Yeah.
If it's
No
too
problem.
uncomfortable, let me know.
Too high, Mark.
Is it?
So remember, give me your fingers.
Yeah.
Slightly lower. Open them up a little bit. There you go. And don't be afraid. You know, it is uncomfortable, but it's not unpleasant. It's fine.
I sense no tracheal deviation.
Okay, and get into the C, cricosternal distance.
Yeah.
I've got a little technique that I use, and I've seen lots of clinicians do it.
Yeah.
They get 3 fingers and they put either side of the trachea, and there's your 2 or 3 centimeters.
Nobody's shown me that. All right, that's great. Yeah. Okay. So I'm going to start submental.
Yeah.
Submandibular.
Yeah.
Gone blank now.
Go on, you're on submandibular.
Submandibular.
So I work. So I'll go from submandibular. I'll go up to preauricular, postauricular, posterior cervical chain, anterior cervical chain. Took a little bit longer than we thought, but that would be a typical session, and you do that with about 4 or 5 students, sometimes in pairs or 3, and occasionally one-on-one if the student is struggling, which Mark blatantly was. But Mark gave actually quite a bad example of a second year. Most second years don't forget that many things, but we wanted to just play with it to let you see the sort of feedback that an ACE is expected to give. Now, don't let it sort of like overwhelm you with the amount of detail there. I've been doing this 12 years. It's a long time. And me and Mark are real specialists with this now. But we do need more people. I'm hoping you can see the value of the way we work, particularly to the student. And that interaction between me and Mark, that's how I would behave with a student. Would have a bit of a laugh. I might even say, can you go and get me a coffee if you're going down for a coffee? Some of them become good friends and eventually become clinical directors of universities.
And give you work.
And give you lots of work.
We're being paid now by guys we trained back in the day.
Yeah, we trained clinical people that we work for now. And they value what we do and they trust our judgment. and they trust that our aces are going to be top notch. Any questions, guys?
Any thoughts on what you just saw, Vicky?
Yeah, great that you can see your wealth of experience, Bob. And I know the more experience we have in doing them, and we pair up initially, but do we get like a checklist for each body system? So I know obviously we're covering the medical, that there's different sides to it, but do we have that checklist?
Yes, they do exist, very much so. I've made my own notes. If you want to mug me for my iPhone, you've got everything on there that you need, basically. So you make your own notes. But it's amazing, Vicky, what you'll just take in from doing it over and over again, actually. I mean, part of the ways that we learn is by having it done over and over again. And in the first instance, it's done by the medical expert, so you know how it feels and it's done properly. And it soon goes in, by erosion to your head, and you know exactly what to look out for.
So
it's helpful.
Here's a typical resource. This is from our friend James Ennis at Chester University, who we're working with next week and the week after and the week after. So he's put together these, which the student uses, okay? So this is MSc Physician Associate Studies Clinical Skills Handbook. And this is the gastrointestinal system, the GI system. So the whole examination is on there. So when you initially start working as an ACE, you'll have somebody with you anyway, but you've got a whole swathe of information here. You're not expected to go away and learn this like a script. You learn the skill set as you go along. It's a bit like driving. It takes a few weeks to get your head around the process, but then you start to see some similarities between the gastrointestinal system and respiratory, the cardio and the MSK. They all have a specific way of approaching the patient, okay, the ACE, and then examining. So for example, what Mark did with the respiratory, if we did GI or we did cardio or cranial nerves, it's still the same process.
But you know something else about our job? I mean, it wasn't touched upon there. Bob was giving very detailed feedback to the student. Sometimes it can be as simple as, that hurt.
Oh, yeah.
That hurt me when you did that. You know, that it can be at that basic level. That really hurt me when you did that. You need to look at that technique and do that again because that was painful for me.
You may,
you know, from that point of view, it can be that simple.
So, you know, you will be expected, you know, to have the student going hands-on with you. Okay. Now, when it comes to hands-on stuff, we have varying degrees of hands-on. So for example, you've got male teaching and female teaching. So this would be things like intimate exams. There's only a few of our ACEs are sort of specialists in this area, okay? Where there'll be gynecological examination and male testicular examination, including what's called DREs, digital rectal examinations. Now, I don't do them. I've never done them. I know how they should be done on a mannequin. So when they're working with me with those sort of more intimate things, we use a mannequin. Okay, is it unemployed? Yeah, self-employed. Yeah. It's self-employed. So it's invoices essentially. And me and Matt have spoken about all of this, and we pay once a month, end of the month. Because if you've got about 5 or 6 invoices for the month, which is what we're hoping you'll have, maybe more, it's easier to just get them all in at the end of the month. And I think you'll agree, Matt, we pay really quickly. Well, ask Mark.
Well, I'm the current employee of Meducate here today, and they're excellent payers, superb.
So
I moved off that park bench, now I'm back in the house. I'm wearing clothes again, and I eat.
You know,
yeah, our customers, such as the universities, they're fairly slow payers, but one of our values is to pay people that work for us on time. And normally you put an invoice in at the end of the month, and that gets paid by the 7th day of the following month. So yeah, so hopefully you'll be happy with that. Do you want me to say how much people get paid? Because probably
but people are going to want to know. Yeah,
everyone wants to know that.
It's the question. It's the elephant in the room, usually, isn't it?
Yeah. So it's £180 per day for normal ACE work, and for intimate work, which is the gynae stuff, it's £250 per day. that is broken down into the hour. So often we sell ourselves by half days. So sometimes that £180, you're asked to do a half day, and that's £90 then. But if it's a full day, it's 180.
So you're basing that on 3 hours teaching?
Yeah, it's 3 hours teaching, which is roughly £30 an hour.
No, yeah. But I mean, it's fun. I mean, I've been an ACE now for, since 2008, and it's great fun, and it's. I feel privileged, to be a lay educator in this world and to be really helping these students, and you do help them. I've kept in contact with many of them on social media subsequently, and they all do well, and we do our little bit to help with that, and that's a nice feeling. It's a good job to do. It's rewarding.
Would there be an opportunity to go and observe a trained ACE and practice? Absolutely. Yeah. So the idea of shadowing somebody is absolutely valuable. So, we'd sort of say, right, you guys are almost ready to be, let out into the wide world. And that's all dependent on how much time you put into, studying the subject, really. And once you've shadowed us, you'll see exactly what we do. You'll be surprised at how quickly you'll start to get into it and then start working. Full time. The idea is that we've got 47 universities out there, and they have no idea how valuable the ACE is. They're getting to understand how important it is now. They're starting to realise the significance of it. And of course, a lot of the clinical directors around the country are people we've trained. So we're making inroads gradually, slowly but surely. It's about educating the academics who've never ever seen an ACE or don't even know what an ACE is. The term was coined, as Mark said right at the beginning, by Professor Jim Powell. And it's a term that he's allowed us to use. It's his intellectual property, but he backs us every step of the way. He wants to see the promotion of the ACE throughout the country. He's not just a professor and an academic, he actually was a practicing GP himself. So he knows the value to the patient. Up until that point, we've got, as Matt says, a very robust quality control sort of program, if you like, outline that is going to cover those needs. And I've spoken at length with a couple of clinical directors who we know, and they're happy with overseeing it. So we can't have a customer, say St George's University, saying, oh, who's given the go-ahead on this? Who's sort of checked your ACEs out? And we can say a senior clinician at Chester University, at Wolverhampton University has checked this out, and they're happy. But to be honest, we never have a problem with the quality. Yes.
I can't stress enough how, once you know what you're doing, what an enjoyable role this is, and how much fun we have, and how engaging the students are and everything. It's like I say, you're working in a bubble. It's a nice bubble. It's good.
Yeah.
Pleasant. It's a pleasant working environment. Academia is very unusual. It's a very different kind of world.
Yeah.
It's very calm and ordered.
It's not a corporate. Okay. No. I know some of you guys are doing corporate role play. It's not like that.
Not like that at all. No.
It's very.
Let me just tell you something about us. You never know what you're capable of. Bob's background, theatre. I'm talking about terms of performance.
Oh yeah.
Theatre, comedy, motion capture work. My background, voices, impressions, voiceover work, and we've reinvented ourselves now with what we're doing. So you never know what you're capable of. And I think all of us who work in performance have the ability to teach. We've all got that innate teacher inside of us. And, you learn what you're teaching and you go and do it. But both Bob and I have learned to love this job, don't we? And it's given us a greater reward, I think, than any other of our
oh, yeah, definitely. Yeah. Things. Yes, definitely.
So you never know what you're capable of until you try and have a go at this. It's very rewarding.
As I said earlier on, I would do this job if I'd won the lottery. I genuinely would.
And I would watch Bob doing this job if I won the lottery.
From your yacht
From my yacht in Poole, yeah. Or perhaps Brixham.
Or Brixham, yeah. Obviously, we love what we do. I'm not going to keep repeating that. And we'd like, to give some other people the opportunity to come along with us,
I hope we've transmitted our enthusiasm in today's session,
Right. So that's the end of it's good night from me. And it's
good night from him.
It's one of those.